We're in the home stretch, and all our presentations actually, I think you'll find it was an interesting mix, but all of them add to our learning and our knowledge and our practice success. So taking it home and helping us be more successful in the challenging space and the wonderful space of being a primary care pediatric practice is Chip Hart again for session 2. And he'll be talking about not simply where your practice is losing money, but how to fix that.
How to fix it. Thank you. Don't clap yet. You don't know if it's going to be any good. First of all, I really would like to express my gratitude again for being invited back to this. I looked at my notes. Someone asked me earlier, and I've been coming to this since 2015. And I'm frankly quite shocked that you guys aren't sick of me yet. I'm also running out of topics. I'm gonna have to start recycling some. Yeah, I'm gonna break out my ICD-9 talk. I really mean it when I say that this is a great audience. I do really like coming here. I don't, like everyone else, it's not compassion fatigue I suffer from, but more, it's tiring to be on the road now. A lot of I'm not in travel shape, and I'm certainly not in shape or mental shape to speak to an audience anymore. But about 10 minutes ago, I was like, I was thinking, okay, this is a great opening day. Tomorrow's going to be awesome. And then I realized, no, it ends like in an hour. As someone who has been to more of these events than all of you, I can tell you that, I can ask you, please don't take for granted how good this particular event is. It's very strong. It's incredibly dense with content. You have a really, really great selection of speakers. I don't know how I end up here every time, but I'm not going to complain. Now, the last couple of years, actually, the conversations we've had have been a little bit more, not esoteric, but a little bit on softer topics, not softer topics, but more personal and HR related things. We've talked about, like, I think people might remember the talk I did, do you work with the wrong people? All right. Because I actually saw some people cry in this room. All right. I saw a lot of this. And so I've been talking about things like that. So to come roaring back right out of the pandemic to talk about benchmarks and now money. These were the topics I talked about 10, 15 years ago. So it's a little refreshing. I just don't want to, I do want to be careful. I would have never thought about this way years ago, but I do now. And that is, I am unequivocally going to be very mercenary for the next 60 or so minutes. I'm going to be talking about the money. And I obviously am cognizant of the fact that the people in this room are not actually motivated by money. Now, what you're largely motivated by is not being ripped off. And that's a different, there's a difference. If you were motivated by money, you would have picked a different specialty, or you would work for people in a different specialty. That's a fact. So when I give this talk and I try to zoom in on how you can generate more revenue for your practice, how you can get paid properly, it's because A, I believe you deserve it. And B, I want you to take that money and not go get a bigger boat or a boat at all, because that's the biggest mistake to do. But I want you to take that money and pay your staff, or make your office nicer, or do the things that you need to do for your patients to be better. So I'm giving that disclaimer. I would have never thought to give that disclaimer in years past, in part because I'm not very bright, but also that the COVID has put a veneer on some things that no one here is going to lose sight of the fact of the importance of your work. And I don't want this scoring, this $ scoring of your work to actually change the way that you think about the work you do. But hey, guess what? You need to get paid to do your work. So where's your practice losing money? I am in the pediatric practice management consulting business. I can waltz into everyone's practice here, and even if I'm wrong, I sound like I know what I'm talking about. All right. And most of the time I kind of do. I understand how your practices work. This is all I've done. Just like you can spot a kid with strep throat from 50 yards away, I can smell something fishy from 50 yards away with your books or the way you're coding or whatever the case may be. And how many people, don't raise hands, we'll just guess, don't identify yourselves, but how many people stop by my little desk out there and said, hey, do you do consults? And the answer is a lot. All right. And I do this all the time. So I'm just going to tell you, like right now, maybe we can do this some year if we've got some volunteer. All right. We can do a live consult in real time. I can show you exactly what I do with someone's numbers. They can be anonymous. All right. You'll have to wear a mask because you'll be blushing the whole time. All right. Good or bad. But I'm going to show you and walk you through the questions that I ask. Now, I'm not going to be able to dive all the way into them. And oh my God, even though I'm going to talk about coding, I'm not going to go into coding details. But I want to show you what I do as a professional to help people in your shoes generate more revenue and do so in an appropriate way. So it's pretty simple. All right. I need to be able to, there we go. Is that me? Am I back? Here's my faculty disclosure. I promise not to talk about anything clinical. That'd be crazy. All right. So changes you may wish to make in practice. This is CME line stuff lined up. I'm about to give you a brain dump and it's going to go fast. And some parts I am going to go deeply into, but most of it I'm going to skim across the surface. It's going to be a lot and it's at the end of the day. And I know everyone here is thinking about every minute he talks is a minute longer in rush hour, blah, blah, blah. So just pick a couple things, 2 or 3. I'm going to probably give you 20. 1 or 2 or 3 will more than pay for your time today. Pick the lowest hanging fruit. All right. Number 2, some of you in here think you're pretty cool and you have this locked down. Double check your numbers. I earn a living from people who think they know what they're doing. All right. And don't. So check your numbers. The worst thing that happens is you say, hey, I knew I was awesome at that. All right. That's the worst thing that happens. Also, finally, I'm going to strongly suggest that everybody in here consider visiting one of your friends this year. Go spend a day in someone else's practice, a day. All right. And then invite them, make sure they come to your practice. And I promise you, you will find something in that other office. You will see that they have solved a problem that you haven't been able to solve for 20 years with about 3 seconds of work. They made it look simple. And you will also see something that makes you feel like a genius because you've solved something that you're like, oh my God, these people are crazy. I could never work here. But they figured this other thing out. And you want to, that kind of exchange is the superpower of this room. And I'm mentioning that because a bunch of the things I'm going to talk about, I'm going to say something in here where you're going to be like, that is baloney. And I promise you that someone within 30 feet of you does exactly what I'm talking about and is kicking butt with it. Okay. Oh, don't worry about this. Here we go. There are 4 categories of where you are losing money. I just organized them. The work you do, how you collect for it, how you code, and how you run the practice. All right. So let me start here. In my original slides, I had these fade in so you couldn't read ahead and try and figure out what I was going to say. All right. So now you're up there. Everyone's read them and they're like, oh, I know he talks about recall all the time. Wait till I get to that section. But here's the first thing I'm going to tell you. Years ago, the first time I ever embarked on some of the consulting work I do, I did this massive survey of our clients. We sent everyone this letter and we were trying to figure out what are the things that are keeping pediatricians awake at night. What are the biggest problems you solve or the biggest problems you have? What's affecting your practice? What's keeping you from succeeding as a pediatrician? And we specifically asked, why are you all complaining about making no money? What is it that's keeping you from making the money? And every one of the answers we got back, I'm not talking like some of them or most of them, like all of the answers were things like, my billing staff sucks and my EHR sucks and all the coding is really, the coding is a disaster and the insurance companies are evil and all of those things are true. But none of the feedback, not a single ounce of the feedback we got was from a pediatrician who said, you know what, I actually don't know what I'm doing. Or I have no idea how to set my pricing. Or I'm afraid to bill for something. Or I don't know how to code. Or it was all external factors. It was all the information we got from people was other people are making my life difficult. So I will tell you that most of the money that you lose in your practice is because of you. You actually control. You have the most control over the things that we are going to talk about. Let's start at the beginning. And that's these two words right here, bright futures. Is everyone here? My slides are going to be really simple. I'm not going to throw a bunch of things up there. I have a ton of links at the end. You're going to get the PDF handouts, okay? And you can just email me too. But I'm going to keep it simple because it's going to be a conversation. But everyone here should know what the bright futures periodicity schedule looks like. I want a lot of nods in this room. And right now, people are like, how do you spell periodicity? P-E-R-I-P. So the AAP has a picture, a graph, a chart saying, do these things at these well visits. The magic of that chart is it's a federal law right now, except for ERISA exempted plans, that they have to pay for every one of those things that has a little dot. Yet, I know that you were all in my class earlier today where I showed you 73% of all the kids between the ages of 3 and 6 or whatever it was haven't even gotten that well visit, let alone that developmental screening, let alone that MCHAT, let alone that fluoride screening, let alone that vision screening, that hearing. Every one of those dots is money. And I can tell you, I should flip back to my old slides. If I use developmental screening as an example, I would challenge someone to come up here and tell me why developmental screening is a bad idea, especially because it's on that list because it is evidence-based. All right. You would be arguing against a large group of people who are smarter than we are, or at least as smart as we are, right? That it's a bad idea. Of course, developmental screening makes a lot of sense. Of course, depression screening makes a lot of sense. If depression screening makes a lot of sense, why is it that about 10% of you do it all the time, 40% of you do it like most of the time, and 10 to 20% of you don't do it? Or you do it and you don't record it, or you record it and you definitely don't bill for it. There is a cohort of people in this room. This room is large enough that there are people in this room who do not bill for depression screening. Worse, there are people who do not do depression screening. I bump into this all the time. The most important work you do as pediatricians is preventive care. It's not by accident that that is the most important work you do financially. So, get a tattoo on your forearm that looks like the periodicity schedule so that every time you walk into a room, you can be like, ... I better see 3 procedure codes on this visit today, or 4. So that's number 1. Bright futures, line it up. The AAP gave you a treasure map, and many of you skip it. Number 2, and I have given a lecture on this topic with essentially this title in this room. If you do not have an active patient recall system in place right now, if you can't tell me, yes, we just did that, or it goes out with every set of statements, or we are on top of it. We know all of the kids who are overdue for immunizations, who are overdue for that depression screening. If you do not have an active recall program in place right now, you are not only clinically weaker, you're financially much weaker. Without patient recall, you do not survive COVID. This lesson's been a little bit easier to teach since March, April, and May of 2020. And I have a lot to say about this particular topic. You have to do this. This is a value-based performance measure. You have more kids right now that we've gone back to our pre-pandemic numbers, you have more kids right now who need your eyes on them because you are the gatekeepers. You and elementary school kids or teachers are the gatekeepers for spotting child abuse and neglect. And this room alone represents tens of thousands of kids who have not seen their primary care physician. You also get paid for it. So when someone comes and tells me, whines to me like, I'm not, this is a lot of pre-COVID conversation, because COVID has messed everything up. And, I'm not making enough money. I'm like, have you been in touch with every single one of your customers? What does your recall program look like? Do you have personalized messages that can go out so you can tell the parents of 10-year-olds, did you know at a 10-year-old visit, I give anticipatory guidance about these things and we give these vaccines? Did you know that over the last year alone, in addition to COVID and RSV and flu, our practice diagnosed 14 kids with X and 21 kids with Y? Do you know that we just added a mental health component to our practice? And we can, if your child is, the list of things that you don't realize you protect your families from, because this is your sole focus, is a mile long, and they have no idea why they should come in for a 10-year-old well visit. You don't promote yourselves at all. This is where these two things, if I walked off I made such a mistake today to say, if you all remember one thing, it's the 99051, and then I had 50 people ask me about the 99051. I should have said patient recall, because this is the single most important thing I teach to people, patient recall. Now, telemedicine. It's funny because this is actually a part of the country where telemedicine is pretty well understood and delivered. And your own people here, you guys have actually, Mark Weissman has actually given a presentation for me once about telemedicine at the supergroup meeting. It was great. Telemedicine is, some of you might have heard me talking about this earlier. From the years, let's pick a year, January 1st, 1990 through March 10th, 2020, what percentage of sick visits were done using telemedicine? Just as a rough guess, make a rough guess. Okay, 0 is a good guess. Okay. I can actually tell you right up before, in the February 2020, it was about 0.3% of sick visits were done using were done using telemedicine, and those are probably like coding mistakes. By July 2020, more than half of the sick visits in the United States, were done using telemedicine. Now that number is much lower. That number is back down to 4 to 9%. It's regional. And it ebbs and flows a little bit, and certainly some practices, I have practices who never did it. I have some practices who are now like majority telemedicine for a variety of reasons. If I had told you in February, if I had gotten this call, I did get the call, but if I were here in July 2019, if I had stood up here instead of whatever talk I gave, I said, hey, guess what? A fundamental modality for the work that you do most often in your practice is going to totally change. You are now doing telemedicine in a month. Whether you like it or not, you would have all like rolled your eyes, and I wouldn't have gotten invited back. Well, until I turned into a genius 4 months later. All right. It was, and if I had told you though, the telemedicine is coming and it's going to absolutely change the way you practice, everyone would have freaked out, but it's changed the way you practice and nobody's freaking out. And the change and the impact on your practice hasn't been profound. You don't go to bed at night crying about telemedicine, at least anymore. You did in May and June of 2020, but after that, everyone got over it. Now, the thing is, we as a collective don't know exactly where telemedicine fits yet. We're getting messages every day right now. They're about to cut it off, or they're no longer going to pay for it properly, or whatever the case may be. I'm saying this not as a clinician, but I hear this all the time, and I certainly understand it. All right, there's a lot of the medicine you do isn't appropriate or comfortable for you or the patient as telemedicine. But boy, some of it really is. Some of it is better and more convenient, and some of it is not. We can say out loud, boy, a lot of these mental health, ADD, lab follow-ups, they're better as telemedicine. We all say it out loud, but as a collective, I'm not aware. I can say all this because Sandy left, and so maybe she can't correct me. All right. But but I'm not aware that there's been any real mounting messaging from anyone saying, use telemedicine for this, and this is how you will get paid. And I'm just pointing out that any change that would have affected 9 or 5 to 10% of all your sick visits, which it is right now, has a profound financial change on your practice. The time to be vocal about how and when and where to do telemedicine and how you will be paid for it is now. So a lot of you as pediatricians are, I'm saying in a room full of people who are not passive, but a lot of you are passive and you're hoping that someone else will take care of this. This is the time to scream, and this is the time to get your patients to scream. Well, let's keep going. So I've talked about the work you do. I want to talk about how you code and bill. I really don't want to talk about how you code and bill because it's an incredibly boring set of topics in a way, but at the same time, this is right in your wheelhouse, and I am going to give you the items that actually have impact. The single most important set of coding mistakes that I've been catching in the last 2 years, this is the fun one. This is the one that catches a huge amount of money. It's immunizations and immunization administration codes. Wow, do people get this stuff wrong? I have, remarkable, a free calculator, 2 of them on my website. You can have them. Why do these calculators exist? Because I make them for myself. I'm doing consulting and I'm looking at numbers for a practice and these numbers don't look right. I better put them in a spreadsheet. And very simply, if you take all the vaccines you gave last year, add up the units. I did 4,000 MMRs and 1,200 flu shots and just add them all up. Oh, I did 21,401 immunizations. How many immunization administration codes should I see? 21,406 or whatever number I just said. And this is not a benchmark I put in there because I don't have a benchmark, but I have a rule of thumb for myself right now. An error rate, it's okay to have an error rate. You can miss, sometimes a mistake is made, but the error rate that you want on your administration codes should be 0.3% or fewer in my book. I like 0.2%. I have a lot of practices who will literally do 21,000 vaccines and you will see 21,000 admins. The average in this room is closer to 2 or 3%. 10 times higher. That means, and here's the thing, for some of you, I am missing 500 vaccines. For some of you, I am missing 500 admins. This is a big deal. This is a huge deal. I find this all the time. Oh, and then what else do I find? I find once a year a practice that doesn't use antigen-based immunization coding. I don't think that's likely in here. But if you don't know what I'm talking about, or if you know what I'm talking about, but you refuse to believe me, please listen. Antigen-based immunization administration coding is worth about $20,000, $25,000 a year per doctor, if my memory's correct. So if you are not using antigen-based IMS admin coding as a rule, and I'm saying use it correctly. I'm not even suggesting you skate up close to using it improperly. All right. The kid has to be 18 or under. You have to provide counseling. Okay. It's pretty simple. But as a rule, I find more money leakage in the immunizations and admin coding than anywhere else. Where else do I see a problem? I see this every day. All right. You all know that we're up to the 9 antigen version of HPV, right? So why are some of you in here billing for the HPV4? It was a different code. And here's what happens. Blue Cross is delighted to pay you for an HPV4, even though it hasn't been manufactured in years, because they pay less. So you keep getting paid, you don't notice. All right. And so I have, just as an aside, you can go to my blog and you just grab it. I have an immunization admin checker. Literally, you can do it yourself. You don't need a calculator to do it. I just make it easy. Go in, run a report, count up all your admins, count up all your vaccines. They should match. Now, depending on, I actually don't know in this area what happens with VFC and admins here. Sometimes in some states, you don't bill the admins. Some of them want you to bill the admins. You might have to adjust, take your Medicaid stuff off. Okay, fine. But those private vaccines make up 30% of your revenue right now. We talked earlier today about pricing just a little bit. And I'm going to give a very succinct piece of advice that covers pricing for everything that you do. If you are not writing off at least 20% on every single procedure, you are losing money. I've been saying words along those lines for 20 years, and no one has ever come up and said, you are wrong. And I've seen with my own eyes what that gap means. Now, there's a lot behind what I'm saying, and I'm trying to simplify my advice as much as possible. Some of you are like, you have already overwhelmed me today with your practice management information. Okay, I cannot take anymore. So just pull one little thread out, like on Harry Potter, and just insert this one. Go back and look at all of your payer payments. At least start with the major ones. Start with your big payers and run a breakdown. Show all the CPT codes you ran last year and how much you got paid for them and how much you charged for them. You do it for Blue Cross, you do it for Aetna, you do it for United, you do it for Cigna. And anywhere that you are not on average adjusting off at least 20%, raise the price. I used to say to people, raise the price until it's $1 more. But the payers got onto that. And so now, I mean, when you hear me say this next, I'm going to say 30% or 40% because that's what your contracts say. We're going to pay you our fee schedule or 50% or 60% of your charges, whichever is lower. And where is this really important? In two places, two massive places. The place where I see this mistake happens the most is with your immunizations. I see too many people who are paying $141 for that HPV vaccine and getting paid $145. And because they're charging $145. All right. You need to write off that money. And I hate to say it, when I'm giving this advice, I feel a little dirty. I am telling you to play the game. Right? This really dumb game that contributes to the insane, capitalization and healthcare financing in this country. But I assure you, pediatricians have no effect on the price of healthcare in this country. All right. At least not this part of it. Okay. You just don't. You could all add $1,000 to everything you do, and you're not even on the radar. Okay. The other place where I see this as a problem is specifically, and I mentioned it this morning, with your E&M codes. I regret not actually creating a slide for this, so I want you to trust me for a moment and pretend I'm a mediocre math professor. And what I'm about to tell you, I assure you is true, and some of you will be able to follow my bad explanation enough to believe me, but if you don't, just trust me on this. The E&Ms are actually a really, really perfect example of the issue I'm talking about with the 20% write-off. Because what happens, because everyone in here has an RVU-based contract. You all have RVU-based payment contracts, even if they don't tell you. They are RVU-based. It's perfectly possible, in fact, it's quite likely that you have an RVU-based contract that, because the RVUs went up for your E&M code so much by 24 to 29% in 2021, that you are actually getting more money right now. And you can go back and check. You can confirm what I'm saying. If you saw your revenue, your per CPT revenue go up for any particular payer at all, even a couple dollars, on those 99212s, 3s, 4s, and 5s, starting sometime in 2021, that's a clue that you have an RVU-based contract. But if you didn't raise your prices at the same time, you probably actually didn't collect all that was coming to you. You might have gone from $75 to $78 for that 99213, but because your price was too low, you only got 80% of your price. I've seen so many of these. And the only person you are pleasing is the shareholder of United Healthcare and the vice president people. They get a bigger glass of champagne on the yacht. All right. You are not raising anyone's prices with their deductibles. You're not charging patients more. You are actually getting paid for the work that you do. This is their skim. Look, hey, a casino. If you've been to Vegas, out in front of they brag on their slot machines. They say 99% return. You guys know what I'm talking about? Okay, 99% return. What they're saying is they collect 1% of the money that you put in the what's it called? Thank you. I was going to call it a jukebox. I don't know what I was doing. All right. And I'm like, wait a second. They're bragging that they have a 1% return. The insurance companies are getting a 1 to 5 to 8% return on your mistakes, in addition to all the money they make in the gap between the premiums and the flow and what they pay you. This chump change adds up to zillions of dollars. Everyone remember, was it Superman 2 when Richard Pryor skims a penny off of every transaction, which then later on people have actually done for real. And he makes a zillion dollars doing that. That's what these guys are doing. So I just slid from pricing into the 2021 E&M changes. And one other important point about the 2021 E&M changes, when the feds changed the rules for E&M coding guidelines in 2021, does anyone remember what the title of the bill was? This required a federal, I think it was a bill. It was the Paperwork Reduction Act. Because, yes, but they actually did this right. The part of the intent behind this was to reduce the charting burden in your electronic health record. Maybe you should have someone come speak about this next year, because this is still invisible to the world. Those charting rules, the E&M rules about medical decision-making, if you are in your office right now, still checking a box for every orifice you looked at, all right, no one cares anymore. That's not part of the E&M measure. All right. It does the rules for coding have changed, and they're designed specifically to help you create an easier and more narrative record. So it's something that you're using for clinical purposes and not being a click monkey. And if you have not changed your sick visit templates since January 2021, now is a good time to call your EHR vendor or call some of your other friends and say, hey, we missed part of this message. Not only were we supposed to change our pricing, but we were supposed to change our chart notes to make them faster and easier. If you are staying up at night doing your charts, and I know people here who are, every 30 seconds I can save off one of your charts is a half a minute of your life you get back. So please change your chart notes. They're supposed to be a lot easier. All right. I mentioned 25 modified visits. I had people come to my table and say, do you have practices who actually do this? And I'm like, yes, all the time. Well, we don't get paid and my patients get mad. And I've heard all of these things before. Okay. And I'm telling you, this is one of the other changes, that one of the other conscious and purposeful changes of the 2021 E&M changes was that they wanted it to be more clear when this happened during well visits. If you remember, before 2021, you're doing a well visit and you do a full physical exam and you take a full history, and then you ran into this, all of a sudden the kid's got otitis media. You can't count any of the physical or history elements of the well visit for that otitis media. And it gets confusing. You've had many coding speakers up here walk you through this. Okay. I've been in this room when those coding speakers, all those rules out the window now. There's no more like, oh, well, that orifice counts for the 213 and that one counts for the well visit. You don't have to count any of those things. That history doesn't matter. You do your well visit, you do your thing, and then you do your medical decision making for the reason that they are talking to you right now. that has an ICD-10 attached to it, that is, as long as it's something they could have and should have come in to see you for on their own without this well visit, you should be billing for it. And yes, I'm making this sound easy. You will have to push back and you will have to fight and you will have to shame the insurance companies into it. And your parents are going to be kicked off that now they have a copay. Guess what? You didn't pick their insurance. And none of this is ever going to change if you just let it keep happening to you. Our healthcare system is strangling us to death, and everyone's hoping that someone else is going to come up with a miracle cure. It is not going to happen. Pediatricians are the only place in that entire process, in our entire healthcare system, that has a chance to bend the curve. We saw the slide from Sandy Chung that showed the pie chart that showed that the United States has, spends the least on primary care of anywhere in the country. And it was 5 to 9%. And the irony is most of that goes to adults. And I hate to tell everyone in here, but you look at the math and you look at the science, our ships have sailed. If we want to bet, everyone in here, that your clinical narrative has already been told. We know this from social determinants of health. If we can tell with about whatever the number is, 70% accuracy, what the healthcare costs of an individual are going to be based on the zip code they're born in, how accurate do you think they're going to be for a 55-year-old male? Okay, about 99% accurate. The only chance we have to save healthcare in the United States begins with the birth of the kid. The feds should just ignore everyone in here. Should be like Logan's Run, and we're all done. And we should focus on the kids. Now, I'm saying all this not to just give you a socialist Vermont diatribe, but the only way that anything is going to change is if you all actually speak up about it. So I'm going to slide right into the other one. I gave away half of my slide deck this morning. The after hours codes. How many people walked up to me today and say, wait, on Monday, Martin Luther King Day, I should do it. I'm like, yes. On Monday, Martin Luther King Day, every single kid you see should have a 99051 attached. Every federal holiday, every Saturday, every night after 6 p.m. That part's easy. So, let's say I'm doing this for round numbers easy. Let's say there are 100 pediatricians in here. There are more than that. And let's say you all see 20 kids each on Monday. All right. So that's 2,000. There should be 2,000 additional 99051s on claims by Tuesday afternoon. Someone at Blue Cross is going to be like, God dang it, someone gave a coding talk. But here we go. I've covered 2 of my 4. How you collect. So, collections in the modern era are a little bit funny because 20 years ago, a huge amount of the money you collected came directly from your patients. And very little money comes directly from your patients anymore. For all the squawking I get about copays and everything like that, literally, you used to collect twice as much money from your patients. Not only relatively, but absolutely, you used to collect more money from your patients. They used to pay you more for a smaller bill. So your accounts receivable. We talked about this a little bit today, and I talked about it at my table a lot today. Your accounts receivable is important. Keep an eye on it. I told you earlier today the number one measure that I like to use. It's the only one I look at. I look at AR days just so I can pick on people sometimes. But if someone tells me their billing department's challenged, I go and take a look. I take a look at their AR in the 60 to 90 day column, and I take a look at how it's changed over time. Also, as an aside, when I can, I like to break it down by payer specifically. I like to see who owes you what. And really quickly, I can find out you don't have a collections problem. You have a Medicaid problem. You don't have a collections problem. You have a Blue Cross problem. All right. Because those are different things. Your net collections is a really key measure. I did talk about gross collections earlier today. Gross collections are just a measure. How much did I charge? How much did I get? And it's a really quick and dirty number to calculate. The problem with net collections is that you need to know what your fee schedule is. Net collections is simply the measure of how much money of the money I expected to collect did I collect. If I expected $73.45 for a 99213 from Blue Cross, did I get $73.94, whatever it is. Your net collections rate should approach 100%, 99, 98, 99, 100%. Many of you struggle to find your fee schedules. They won't send them to you. They may even be inaccurate. You can, however, I would rather have a guess about the fee schedule. I'd rather know that they are in the zone, and I'll explain why in a second, because that's the next box. You can effectively create a fee schedule by looking at your EOBs. All right. If you have been getting paid, all right, especially after you fix your prices, right? And if you've been getting paid $19.10 for that 90460 on all but a handful of your IMSS admins for Blue Cross Blue Shield, that's probably your fee schedule. And I'd rather have you, because this is the next word in the line, the automation, I would rather have you presume that you should be getting $19.10 and automate your payment posting process than to just do everything manually and actually never know. And so that's why I slide into automation. If you are not using your billing system to automatically post every single insurance check, you are paying someone a lot of money to do very simple work. And don't get me wrong, it's not always easy. Some of your payers make this very difficult. And you can only properly do this, again, if you have your fee schedules. If you blindly post every single check, you will lose a lot of money because the payers will gladly just adjust things off because they made up a new fee. All right. But a well-run billing office has the majority of their primary fee schedules loaded into the computer. So when you get that $50,000 Blue Cross Blue Shield check, you can post 90% of it in 10 seconds. All right. There are other automation tools that are also involved. And anything I'm going to say right now, you already know. Okay. Whether it's especially because some of you use companies like Athena, who really do understand this. They're good at this. Any of those tools that automate your billing process, you should be using your portal to collect money. If you are not using your portal to collect money, you are missing out massively. I will tell you, I work for a company. We have a portal. Because the portal's a web thing, we were able to turn on the money collecting part before we told our clients. Our clients started getting money from the portal before they even knew it was turned on. Because people like open up the app and they see it, oh, I owe $25. They hit it. Like, you didn't have to bill them. All right. And that's not a game changer, but this is the 1 or 2 or 3 or 5%. Use your portal to collect that money. Use your portal to send your statements or to confirm stuff with people. Use anything you can do to automate your billing process. You should. Now, I think I have a slide. So a pause for data measurement. It didn't dawn on me until like just before I started. I'm like, oh gosh, I have that slide in the middle of this deck where I talk about everything I talked about this morning. These are the numbers. These are the measures that I use when I dive into a practice right away to figure out what's going on with them. Now, let me see. 1, 2, 3, 4 of these I can get. And so again, maybe next year I'll do a live demonstration of how I look at a practice. I can just grab a random PCC practice and no one will know. But if someone else here wants to do it, be my guest. One of the things I do, the first thing I do when I meet a practice is I gather the data of all the CPT codes that they did in the last year. And I don't this part will be obvious. I don't run it up through yesterday. I back it out about 3 months. So I make sure their collection, the money's been collected. So right now I might do like October through October 21 through October 22, all the CPT codes they did, how many units they did, how much they charged, and how much they collected. And with those numbers, I can figure out 100 little different ratios. I can calculate how many immunizations they did and how many admins they did. There, I figured that one out. Are they missing stuff there? I can look at their immunization codes and determine whether or not they're using old immunization codes. I figured that one out. I've already for a lot of practices already looked like a rock star. Just found you $10,000. All right. They're not in this area. I've been working with a practice over the last 3 months that was going through this. And that's when we discovered is that their immunization coordinator had somehow lost her mind and stopped ordering VFC vaccine and was giving private vaccine for about 6 months. It's a $150,000 mistake. That's why if you saw me texting when I was at my desk I like the sound of that. That's how I was trying to follow up on that. Okay. And how do I find stuff like that? I run a list and I'm doing some comparisons. I'm like, wait a minute, how come? And I should be clear. I don't want to take credit for that. They found it. And that's how we confirm some of it. So I can also, from that list of CPT codes, I can instantly figure out the sick to well visit ratio. I just go right over to the column that has the sick visits and I add up the units, and the column that has the well visits and I add up those units and I do those two. And we talked about what that benchmark looks like. I can calculate a very rough revenue per visit. Now it's a little rough because visits are a somewhat nebulous thing, but I can add up all the E&M visits. How many 3s did you do and 391s and maybe even consults? And I can add up your telephones and add those up. And then I add up all your revenue and I divide. There's your revenue per visit. I can do your pricing from here because I have how many units you did of each CPT code and how much you charged for them. I can drop those right into the RVU spreadsheet and it will turn around and tell you, you charged on average 171% of Medicare. You don't have to do any of the work except for cutting and pasting. I can figure out your E&M distribution from here. I can look at your ratio of antigen-based IMS admins to non-antigen-based IMS admins. If you go back to my benchmark talk today, you'll notice most of the reports from there can come from this. Well, not, at least half or 2/3. I can look at it and be like, oh, here's their new patient volume. That was another one I talked about. So these are the numbers that I like to look at. And this is the map of where you are losing money. If that well visit coverage is not at 95%, you are losing money and we need to recall. Your screening, right? Here's a trick, depression screening, all right? I want you, if you can log in your office while we're doing this, go ahead, all right? Some of you can, or when you get home tonight, run a report and count up how many 99394s you did. Those are adolescent well visits, right? If you did 1,000 99394s last year, how many 96127s should you have? At least 1,000. You should probably have more. Okay, probably. But when I see a practice have 1,000 99394s and 175 96127s, and I can look around this room and let's see who doesn't look me in the eye right now, because that is you. All right. I guarantee there are people in here who have those numbers. There's a free one right there. And you need to stop and ask yourself. And I've heard every answer. Well, some of my doctors don't like to do them. Some of my doctors don't record it. We record it. It's really important to us. Oh, it's really important to us. We just don't like to bill for it. That's a weird language to speak to me. You can do the same. You can eyeball your own numbers really quickly and be like, well, look at all these 391s and 392s. And do I actually have hearing and visions that line up with all of those? Hard to say. So you can eyeball these things really fast for yourselves. All right. I shop in this pond. I wanted to just give you that. Now, I just want to make sure. My last category. Now, I hope until I got to this category that I have found something for everyone in this room. If I found one thing for you, it's worth it. The day is worth it. Actually, I was going to mention something else. I'll think about it in a sec. Here's the other biggest leak that I see. And I realize that there are employed clinicians in this room, and there are employer clinicians in this room. I'm speaking to the employer clinicians right now. But I'm also speaking to you as employers in terms of how you pay each other as partners. The single biggest category of consulting requests I get right now is how to deal with partnership agreements and compensation models. How much do we pay ourselves? Do I buy this practice? How much do I pay a new doctor? And the question, you see it on SOPM like literally every 2 weeks. What's the going rate for a doctor in so-and-so in Baltimore? And my answer to this is always, I don't care. It does not matter what the going rate is, because first of all, someone made it up. All right. And someone made it up, and the going rate somewhere else is irrelevant. This doctor is only going to earn so much money for you. You have overhead, you have the cost to get the chair in the salon. All right. That's what those exam rooms cost. That's what you get as the owner, and they can have everything that's left. And so if you are losing, I get this. Oh, do I get this often? Oh, I'm really struggling. It's been a really tough 5 years. I say, all right, okay, solo owner person, give me a list of your doctors and what you paid them, and we'll run some productivity reports. So this person brought in $300,000 and you paid her $200,000. So you probably subsidized her by $100,000+. Okay, that is totally. That's unfortunately too normal. If you are not, as your business owner, acutely aware of how much you are paying your employed physicians as well as yourselves as employed doctors, one of the biggest mistakes that you make as owners is you blend the hat of doctor and owner. You are two different people. You need to look at yourself as an employed physician. How much would I pay me? I mean, I know I'm awesome and the best doctor ever, but how much would I pay me? Actually, you know what you all think? Well, I'm the one who they all come to see. Okay, ignore that. How many kids do you see, and how much revenue did you generate, and how much would it cost to replace you? That's how much you should pay yourself, and then you get the money that's left over at the end of the year. I have a lot more to say about that, but how you pay your clinicians is a huge leak in most of your practices. And that's how do you pay yourselves. And then this big one. I guess I'm standing in a room that represents a GPO. Am I correct? Okay. So this one's easy. I assume, okay, if you're here, someone has talked to you about joining a vaccine buying group. I can say in all sincerity, I don't care which one you belong to. The worst vaccine buying groups are way better than no vaccine buying group. And I assure you that the people who sell or manufacture vaccines for a living will love to tell you, they will look you in the eye and say, just buy directly from me, get you the best deal. They're fibbing. And there is actually a pretty substantial one represented in this room. They're great. I don't think I have to give this advice here, but and actually 10 years ago, some number of pediatricians were not part of buying groups. I once spoke to a guy who owns one of the largest buying groups in the country, and he told me, he's like, every doctor I sign up is worth $10,000 to me. All right, there's that much margin in this business that he could make that much on you and still save you money. All right. My second to last comment, and then I'm done. I've actually never had anyone hold up a sign that said stop before. I've had the 5-minute warning and the 10-minute warning plenty of times. I've had the -5 minute and the -10 minute, but I got to stop earlier today. It wasn't you, don't worry. I know, but I was like, ooh, okay. So if you do not belong to SOPM, it's $30. It is the section on administration and practice management from the AAP. It's where all the cool practice management nerds go. Every single thing I've ever spoken about up here has been a topic on SOPM multiple times. This is where the people who own practices and want to be better at their jobs come and speak. And there's a practice management wing of it right there. Go talk to Rachel. She's the queen of it. All right. It's the best. I mean, it's like $30 and it's a priceless amount of help and information. So when you get this magic slide deck from our friends at Children's National here, or you email and ask for me, I actually, maybe for once in my life, put references for every single thing that I talked about in here with links and the whole 9 yards. So I'm just going to, don't take a picture of it. It's free for you to email me and ask me for it. I'm not going to collect your email address. I don't do anything like that. Or they are supposed to post them and host them shortly. So they're all on here. You can read. Look, this is the big one. E&M changes, videos, handouts, AAP documents, all about everything I talked about when it comes to making your chart notes faster, getting your pricing right, and how to code for this stuff. It's all in there. So Dr. Weissman needs to come back up and tell you how to win your lottery ticket or get your parking or whatever. I just want to say thank you for everyone who had the patience and stamina to get through the day. Apparently there's time for questions if people have any. There are microphones and oh, someone's holding a microphone. Or are you like delivering it?
I'm just the passer.
You're the hostess. All right. If anyone has a question, if anyone dares to ask a question, I will be, there's one right here. I'll repeat it if you want to yell. Mm-hmm. Deductible. Oh,
It's gone to their charges. And then, so essentially they talked to my billers. My biller said, just when you come in, this is what my biller said, when you come in, just tell the front desk, I don't fill any of those out. I'm not going to fill any of those out.
So the comment was when these PHQ-9s and the depression screenings go to directly to the parents complain, and you have a biller who is oddly still employed by you. Okay. I mean, for real. Like what? I mean, so first of all, seriously, I guarantee you that is not the first time your biller has said something that undermines the entire construct of what you do. I would probably be parting ways with my biller. But that aside, that is, if this is, unless you're talking about ERISA plans, that is also illegal. Okay. And it is probably ERISA. I am also then going to say, tell those parents to, I almost swore into the mic. Tell those parents tough luck. Are you trying to tell me this? It makes me so mad. This $10 charge for a depression screening that is medically proven to identify kids who have depression. We all saw Sandy Chung's slide up here. Everyone who has a kid right now knows this. And I don't have to tell this room. Who you're going to walk out of my office and go to KFC on the way home or buy some, you have stupid Netflix, which is 3 times the amount, and you can't spend that on your kid. Any parent who comes to you and says that should be ashamed. And the thing is, all right, I was not channeling a pediatrician because you all would never say that, but you ought to be able to look them in the face and stop and say, what kind of cognitive dissonance am I experiencing right now that you actually don't want to screen your child for depression? And so I believe it is your job as a pediatrician to educate that parent as forcefully as possible about the importance of what you do. You are still by far not only the best healthcare that family is ever going to get, you are the cheapest healthcare that family is going to get. And all you have to say is look a mom in the eye, say, last year we had fill in the blank. How many kids die by suicide? Last year we had how many kids get diagnosed with depression? We had how many kids? I mean, you don't have to make up the stories. Say this test isn't perfect, but it lets me really quickly identify. And if you have a parent who isn't that isn't ringing the bell for them, you need to have a secondary discussion with them. That's not someone I would want in practice. That's, can you imagine if something happened and you let them talk you out of a $10, $20, whatever you charge for that's, so no, don't let that happen. All right. Okay. Last chip question. Make it good.
It's not a question,
Uh-oh.
Dr. Balakirsky Pikesville. But it's a comment to what the conversation going on now. But if that $10 and parents call insurance, they check whatever we bill, and insurance said it's included in your visit.
So a screening that is in the Bright Futures periodicity schedule is not included.
That's what not
Then
insurance said.
anything I'm ever going to say about this is you're going to hear me. I'm never going to change my tune. You fill out a hassle factor form with the AAP. You get it in writing that this insurance company is somehow embedding this thing. And then you tell the parent, well, I'm still going to charge you. No pediatrician, I'm going to say something that's really out of school right now. No pediatrician is going to jail because you force them to do a depression screening. I'd love to go to that trial. Oh, yeah, this poor pediatrician up on, say, and United Healthcare is in there. This evil pediatrician was trying to screen my children for depression. It just doesn't happen. So, no, you need to be, unfortunately, you are reasonable people who are actually in the business of helping people. And you're partnered, unfortunately, with large organizations whose business it is to provide value for their shareholders. You will always be at odds. So you have to behave in a manner that is not natural to you when dealing with them. It is, I wish I had some better answer. So keep fighting. I think that answer is bogus, and you need to be the squeakiest wheel in the room. So there you go. I'm going to turn this over because I could get angry all day. Thank you.